Yeah, let's start with our case. With me is Giora Weiss from New York and Kolja from Frankfurt. And we want to show you a procedure which is, let's say, not really new, but pretty new in Europe here at least. And I think this will may become a very important one. That is about pulmonary artery denervation. Can we have the slides for the case history, please? That is an 81-year-old female patient with pulmonary hypertension, progressive dyspnea during mild exercise. I closed her ASD back in 2003. She had a small residual shunt, which was hemodynamically not significant. Paroxysmal atrial fibrillation started many years later in 2019. Then she was referred to another center. They did, unfortunately, surgical PVI, pulmonary vein isolation, and surgical LAA closure in 2019. She also received a pacemaker in 2022. She is suffering from diastolic heart failure, moderate mitral regurgitation, and also morbus Osler. And echo showed a PA pressure of 45 millimeters of mercury. LA and RA are enlarged. The right ventricle is enlarged, reduced RV function, ejection fraction, left LV ejection fraction 55%, moderate MR and TR. Right atrial pressure was 6, PA pressure was 45/22, pulmonary capillary wedge pressure was 10, pulmonary gradient was 19, cardiac output 4.2, pulmonary vascular resistance 4.5 Woods unit, and QP2QS is 1.16. This is the small residual ASD after ASD closure. Pulmonary hypertension of unclear etiology, maybe it's a consequence of pulmonary embolism. So CTEP was suspected but not formally confirmed, morbus Osler, and RV dysfunction. Giora, would you like to show the catheter and explain the concept, how it works?
So I hope you can see it here on the... You can see it here. So it's an 8 French catheter at the loop at the tip. You can see there is multiple loop electrodes. In the large catheters, there are 10 loops electrodes that deliver the radiofrequency energy. It's not just a dumb delivery of the ablation energy. It also has multiple sensors. It senses the temperature, senses the impedance, senses the amount of power that is being delivered. So we want to make sure the delivery of the radiofrequency is both effective as well as safe, because we don't want to cause any injury to the pulmonary artery. There's a large experience of several hundreds of cases that have been done already that shows no pulmonary artery dissection or perforation or stenosis. So it's you can see it's very round, very smooth catheter that should be very safe and straightforward procedure. So once we activate and if we can see also the console, I will show you the console that generate the radiofrequency energy. So you see it measures the temperature, it measures the impedance. You want to have an effective temperature. The effective temperature is between 45 and 55 centigrade. And when we measure the time of the effective therapy, it has to be at least to get to 45 centigrade with the appropriate impedance as well as the power. So again, it's what you want to see here is a combination of effective treatment, but definitely safety, not to cause any damage, any injury to the pulmonary artery. And that's when we see once we activate it. If you go back to the fluoroscopy, please. You can see, so we have 10 electrodes. We don't need to activate all the 10 electrodes. As Horst said, the majority of the sympathetic nerve trunks are on the left lateral side of the main pulmonary artery. So we select 3 electrodes that really cover all this lateral segment of the main pulmonary artery. We activate each of them at a time. We can see here. We can count them by numbers. We can see the free end of the catheter. But you can see how stable, all the numbers are very stable, and that tells you that it's a good contact.
Horst, interesting case to start us off. A lot to find out in due course, and be interesting to get the feedback. Thank you very much, and then we'll move to the next case. All right, thank you.
Thank you.
We just did, Dr. Siebert just did that first case in Germany of PADN with Dr. Weiss as the proctor. So we'd like to ask them a few questions. Particularly, I'd like to ask you, Dr. Siebert, what's your impression in terms of the procedure ease compared to what you do usually?
Should I be honest?
Should you be honest?
It's too easy, almost boring, because it's just right heart catheterization. So I wanted to have some more complex, but that was not the case.
And that,
Good news.
that was also not the usual anatomy. It was not an unusual anatomy, and you made it look very easy.
It was. Congratulations. This, I think, if this can be confirmed in further studies, this can really have a large impact on the treatment of these patients with pulmonary hypertension.
Yeah, because basically in terms of treatment options today, what do they have?
Yeah, it's very limited. So, and most of these patients are suffering from severe symptoms like this one here. She could not climb one stair, so it's really severe disease, and there are not many options. And the trial results you give a lecture today about this are positive, and if this can be confirmed, big impact.
I agree.
Dr. Weiss, your impression? And this is now, how many cases have you done actually?
I done over 20 cases, and for Professor Shivert was the first procedure, and the learning curve is very, very quick. Once you understand the technology, the catheter, the anatomy, it's almost straightforward.
How many so we talked about the randomized trial, the one of patient with heart failure. How many cases do we allow for rolling?
So we for the randomized clinical trial, we will allow up to 2 procedures per operators, but honestly, I believe that 1 will be enough to understand the procedure.
Yeah, do you think that Dr. Sivertje would be ready to do the next one on his own?
So maybe we can randomize this patient perspective.
Yeah.
Very important.
Yes.
So with that, I think, we hope that you'll be part of the randomized trial.
We are.
To be enrolling patients. And I don't think I have any other questions. Thank you so much for your time, and see you today.